So greetings everyone and welcome to the 78th session of the online Optom learning series. Let me introduce to you our speaker for today. So today we have Dr. Hasanain Shikari. He is an ophthalmologist, a vitreoretinal specialist who practices at his own clinic, which is named as AREDS Clinic at Opera House in Mumbai, India. After his ophthalmology training in Mumbai, he pursued specialty fellowship at Boston. Dr. Hasnain has authored numerous journal publications as well as textbook chapters. And not only that, but he's also lectured at several national as well as international meetings in ophthalmology. He is also recipient of several awards for his presentations as well as for the community service work he does for the eye care community. Very recently, he has a video on digital eye strain, which was shot of the COVID-19 pandemic. And I think you guys must go and watch this video and understand and prevent. It's about understanding and how to prevent computer vision syndrome. And the Times of India has also published an article quoting Dr. Shikari to raise this awareness too. Yeah, so thank you, Dr. Hasnain. Welcome to our platform.
Thank you.
Today, Dr. Hasnain is going to talk to us about the very basic insights about the age-related macular degeneration, ARMD, which is kind of a leading cause of blindness in most of the countries as well. And he's going to share his views on the latest treatment options also available and how can we as primary eye care practitioners can help to detect, diagnose, and manage ARMD. So I would just leave the screen time to you, Dr. Hasnain.
All right, thank you, Fakhruddin and Zulfikar. It's a brilliant platform. Thank you for having me here. So I'm going to start off very quickly with the basic anatomy of the retina as it applies to our talk on age-related macular degeneration. The retina is made up of 10 layers, and to grossly group them, we have the important layers, which are the photoreceptor layers, which form the outermost layer of the retina and lies above the retinal pigment epithelium. The retinal pigment epithelium is the layer that is responsible for maintaining the extracellular matrix and the activity of the photoreceptors. And then we have the Bruch's membrane, which maintains the blood-ocular barrier and is composed of a central elastin core, which is sandwiched between the layers of collagen. So the photoreceptors, RPE and Bruch's membrane form the very important layers of the retina, which are central to age-related macular degeneration and its pathophysiology. The choriocapillaris are the innermost layers of the choroid, which are situated directly beneath the Bruch's membrane. And this supplies most of the blood or oxygen to the outer one-third of the retina, which includes the layers up to the photoreceptor layers. It also helps remove the waste created from the photoreceptors and the RPE activities. So together, the RPE, Bruch's membrane, and choriocapillaris maintain the health and function of the overlying photoreceptors and thus support vision, and are, again, like I said, central to age-related macular degeneration and its pathophysiology. So here we have the main layers: the choriocapillaris, the retinal pigment epithelium with the Bruch's membrane, and the photoreceptor layer. Now, as the name implies, it's age-related macular degeneration. So there is no specific reason known as to why this affects mainly only the macula. But because the macula is the area of retina that's responsible for central vision, this is the layer that's affected. This is the area of the retina that's affected, and causes a pretty dramatic decline in functional vision in a lot of these patients. In a normal exam, the fovea is located at the center of the macula and appears to be darker than the surrounding retina. So what exactly is age-related macular degeneration? It's one of the leading causes of blindness in the world, more so in the developed nations, among 65 years and older. As the population ages, life expectancy is increasing. The numbers of patients affected by age-related macular degeneration is expected to be currently around 195 to 200 million patients. It's a degenerative disease that affects the macula, characterized by loss of the central vision, since the macula is responsible for central vision. As the name implies, one of the foremost risk factors is an increasing age. It is rarely seen under patients in patients under the age of 50, though there are a few isolated reports of patients above the age of 40 and less than 50 also presenting with this. In the American population, about 30% of the American population above the age of 85 has age-related macular degeneration, which is quite a big chunk of people above the age of 85. Smoking is one of the most significant modifiable risk factors, and this was also confirmed by the AREDS study. So smoking cessation should be encouraged to prevent progression of the vision loss. Current smokers are 2 to 4 times more likely to be affected by macular degeneration than age-matched non-smokers. And abstinence of 20 years or more reduces the risk of that person to that of a non-smoker. So this is, as is also seen in a lot of lung conditions as well. There is some family history, so it is a multifactorial in nature, but a positive family history does confer increased risk of the patient developing macular degeneration. In terms of race, the polymorphisms in the complement factor H gene is associated with an increased risk among Caucasians. So the complement factor H inhibits complement, and the polymorphism weakens the ability to downregulate the complement activity. So as a result, with continued the activation of the complement, there's continued inflammation and pathogenic degeneration of the macula. This is seen more commonly in Caucasians. Asians and Hispanics have an increased prevalence compared to African Americans. So a lot of Southeast Asian patients do have a prevalence to get into age-related macular degeneration. Other speculated risk factors for AMD include obesity, hypertension, hyperlipidemia, hyperopia, light iris color, female gender, cardiovascular disease, and nutritional deficiencies. Coming to classification, age-related macular degeneration is grossly classified into dry, which comprises 80% of the cases, but thankfully this is not very disastrous in terms of vision loss, and the remaining 20% is wet or neovascular or exudative macular degeneration. However, this accounts for 90% of the cases with advanced stage disease and severe vision loss. So wet macular degeneration is responsible for lower visual acuity in these patients. Dry ARMD, as you will see in these photographs here, is characterized by the presence of diffuse or localized drusins, which are more at the posterior pole. There is a loss of RPE and photoreceptors in geographic atrophy, which then appears as a well-demarcated yellowish area, often with choroidal vessels seen underneath. This may symptomatically produce scotomas in vision. In wet ARMD, there are newly formed blood vessels, which is called choroidal neovascular membranes. As in diabetic vasculopathy, CNVs are immature and leaky, and as a consequence, they leak subretinal fluid. There's presence of subretinal heme. There can be lipid deposition. There can be pigment epithelial detachment, in which basically the fluid separates from the RPE from the Brooks membrane, and subsequently this can lead to fibrotic scarring. So AREDS classification is the AREDS was the age-related eye disease study in which they classified patients to allocate these patients to different groups. So this was based on a clinical examination of the patients, where patients with fewer than 5 small drusins, or which were less than 60 microns, were classified as no AMD. Patients with multiple small drusins or some intermediate sized drusins, which were like 60 to 120 microns, were classified as mild AMD. Intermediate AMD had patients presented with extensive intermediate sized drusins, more than one large drusen, which was more than 125 microns, or non-central geographic atrophy. And advanced AMD, the patient had central geographic atrophy or neovascularization causing vision loss. So visual acuity was in 20/30 in one eye. Now, as a benchmark, an average optic disc is around 1500 microns, and the vein width near the disc is around 120 to 150 microns. So drusen with diameters the same width as a vein near the disc is considered large. This is just to recap what we have as early, intermediate, advanced non-neovascular AMD, and advanced neovascular AMD. So now coming to the pathophysiology, we'll go through this really quickly. The Brooks membrane is again central and key to this. The Brooks membrane functions as a structural support that is permeable to fluid and small molecules such as oxygen and glucose, but it acts as a barrier against neovascularization. So it sort of protects the retina from the the new blood vessels sprouting through the choreo capillaris. This it does by containing the molecules in the elastin layer that are anti-angiogenic. So basically, imagine sort of like a anti-vascular layer that has been coated onto the Brooks membrane, and that protects it, protects the retina from neovascular, the fronds creeping in. As the RPE functions on a daily basis, it's creating vascular endothelial growth factor that passes through the Brooks membrane to the choriocapillaris. However, the anti-angiogenic molecules within the Brooks membrane prevent growth of neovascular capillaries from the choroid, and so they help in preventing wet AMD. The retina pigment epithelium, we have to realize, is a highly metabolic tissue. It's a neural tissue, and as a result of which there's a constant production of metabolic byproducts. The Brooks membrane tends to accumulate the debris in the elastin lamina and the drusen between the collagen layer and the RPE basal lamina. So that is the underlying pathophysiology here. That is, the Brooks membrane becomes less permeable. So the waste products from the metabolic functional activities of the retinal pigment epithelium start collecting, and this is what we see as drusens. This leads to an obstruction to the pumping of waste from inside to the outside of the eye by the RPE and may cause pigment epithelial detachments. And then when there's excessive material deposit in the Brooks membrane, it causes atrophy by obstructing the choroidal blood vessel, the nutrition from the choroidal blood vessels from reaching the photoreceptors, and also the waste removal. So there's basically a complete derangement of the normal functioning of the metabolic pathway here, resulting in death of the cells. Now, with aging, there is thinning and breakdown of the central elastin layer within the Brooks membrane. So this causes two problems. One is that because the elastin layer contains anti-angiogenic proteins, those are reduced, and as a result, there's increased risk of neovascularization. Also, the breakdown of elastin causes the production of elastin-derived proteins, which are pro-angiogenic. So they actually cause more angiogenesis happening. And the breakdown of the Brooks membrane also causes a physically reduced barrier to neovascularization. So essentially, there's a physical as well as a functional loss here, which results in new vessel fronds creeping into the space between the Brooks membrane and the RPE. So like you can see in the diagram here, you see how the Brooks membrane, there's presence of drusens, and then there's damage to the elastin, which causes new the anti-angiogenic properties to come down. And as a result of the metabolic byproducts of the RPE functioning, the pro-angiogenic factors, the VEGF protein, diffuses into the choroid, stimulates new blood vessels, which then creep into the physical loss in the barricade to the area under the RPE and cause damage over there. Now, in terms of signs and symptoms, when we look at dry ARMD, the early stages, the drusens are the clinical hallmark. They are the earliest exam finding. You can see them scattered at the posterior pole. They are basically deposits, as already discussed, of extracellular matrix and inflammatory components in the Brooks membrane. They are usually pale yellow and can be classified as hard or soft based on appearance. Hard are more defined margins, smaller. Soft are more confluent, appear like a cotton ball. Soft drusens are things that we need to watch out for because they're generally pathologic, not found in young, healthy populations. And an increase in size of the soft drusens can usually herald the progression of these patients to maybe wet ARMD in the future. Most of these patients do not have any visual symptoms. They usually present with normal vision. Their vision may be 6.6, 6.9. Some of them may complain of difficulty in night driving or identifying dimly lit objects. This is because of loss of rod receptors earlier than the cones. Some of them may also present with reduced contrast sensitivity. Now, what is important here to note is that a lot of these patients are above the age of 60, and as a result may have other ophthalmic comorbidities like a reduced tear film. They may have some degree of cataract. So it's very difficult to pinpoint an exact cause of the reduction in contrast, the reduction in night driving vision, etc. But yes, dry ARMD may cause these symptoms. Atrophic AMD or geographic atrophy usually causes a slowly progressive atrophy of the photoreceptor, RPE, and the choriocapillaris. There's thinning and loss of pigment. It's slowly progressive over months to years. It may be bilateral, where the severity and progress between the two eyes may also differ. But patients usually don't have a very dramatic course, and their vision remains stable for prolonged periods of time. Late stages of dry ARMD are usually associated with hard drusen, small, round, yellow-white discrete spots with focal disruption of RPE. There may be atrophy of the RPE, and as a result, formation of central scotomas. There may be an enlargement of the atrophic area, appearance of pre-existing drusens or choroidal vessels becoming visible, leading to geographic atrophy. Patients, again, some of them may show a distorted vision based on RPE disruption. Some of them may have slowly progressive central vision loss, which progresses from a period of months to years. Wet ARMD is, it comes in about 20% of the patients, and the patients usually may show soft drusens, which are larger, confluent, with irregular margins. They may coalesce to form drusenoid RPE detachments. There may be macular elevation on clinical examination due to either subretinal fluid or blood associated with clumps of exudates. So over here, you can see there seems to be like a drusenoid elevation of the RPE. The margins aren't as very sharp. And if you look over here, you'll see presence of a grayish membrane, which is characteristic for a choroidal neovascular membrane with exudation. So there's fluid coming out, which has now resulted in the formation of exudates at the macula. If we were to investigate these patients, we would see presence of fluid in the areas under the retina on an OCT, and we will be coming to that later. So these patients usually complain of profound central vision loss, which progresses very rapidly. They will have distorted vision where straight lines appear wavy. They complain of inability to recognize people at a distance or at near. They complain of inability to read small prints, not being able to see their mobile phones. If one eye is affected, a lot of these symptoms can be missed because a lot of patients don't realize that the vision in one eye is low. We've had so many patients who come in with advanced stages of wet macular degeneration in one eye with early onset in the other, because that is the reason why they've come in, and that's when they actually recognize that their vision is low. So coming to the first poll, examination and testing. A patient with suspected macular degeneration, what would be your first diagnostic test that you would perform? Would you, do an spectral domain OCT? Would you do a fundus photography and fluorescein angiography? Would you do Indocyanine green angiography? Would you do OCT angiography? None of the above? Would you just, go clinically, or would you do all of the above?
So the 6% majority of them think they want to do a fundus photo as well as a FFA,
Okay.
fundus angiography, and followed by
All of the above. Okay.
all of the
Quite a
above
few.
tests, and then SDOCT, and very few people would want to do ICG and OCTA.
Okay. So all right. So it's a good outcome. Maybe things may change at the end of this. Let's see. Let's take a look. Now, in terms of examination and testing, the Amsler's grade is as an optometrist, as someone who's checking vision either in a clinical setup or in primary practice. An Amsler's grade remains one of the major tools that we should be employing because it's cost effective. It's a pictorial tool that identifies the presence of metamorphopsia or scotomas. It may not really show a lot of changes in dry AMD, but in wet AMD is more likely to cause a sudden change in vision. What I like to do is I usually like to give these Amsler's grid to patients at home, because for me these work as sort of like a sort of like a home OCT, if you will, because the grid can be rechecked and recorded at home by the patient, every couple of days. And if they notice any changes in vision, they come into the clinic earlier than required. So that's what I usually do. The earlier the changes are detected, the better the likelihood that a CNV can be detected at treatable state. So the key here is treating the patients with wet ARMD, treating them as soon as possible to prevent further damage to the sensitive retinal tissue. A fundus exam is also very, very important. There's absolutely no giving up on a fundus exam. It's a very good idea to document the presence of drusins. The best way obviously is a fundus photograph. So yes, that's correct. A fundus photograph is one of a major ways of documenting and following up these patients. The atrophy of the RPE would appear as a well-demarcated area of yellowing within the retina with easy visualization of choroidal vessels. Drusen may also be present in cases of wet AMD, but CNV are usually the hallmark here. You may see these yellowish, grayish areas of retina which have leakage or exudation or frank heme, and these would be a classical hallmark of wet AMD. Fluorescein angiography in patients with dry AMD and atrophy usually present with a window defect. So you can see the entire fluorescence. You can see the entire fluorescence of the choroid. The flush is seen through very easily because the RP here is damaged and is unable to block the fluorescence from the choroid. So you see this as a window defect. Drusins would appear as areas of punctate hyperfluorescence. So you can see those over here. And wet AMD may show leakage from CNV. So you can see over here, there's a sort of a leakage happening here. And the area that's covered by blood will show as areas of block fluorescence. However, fluorescein angiography does have its limitations. If you do a very good clinical exam, if you're able to take very good fundus photographs, a lot of patients nowadays don't really need an angiography, especially because this is, we call this an invasive test where you're injecting a dye with, its inherent side effects. And in the generation, where the OCT, the optical coherence tomography, has advanced so much, I think in most clinical practice, the OCT has become one of the primary tests that we perform. It's very easy, it's quick, and can be easily employed for follow-up as well. A lot of these OCTs come with built-in fundus photographs, so you can do both of those at the same time. In dry ARMD, we would see drusins, which essentially present as elevations of the RPE, or a geographic atrophy. So if you look here, you see these are the drusins, and a corresponding OCT will show these tiny bumps in the RPE, the red being the RPE. You won't see any presence of fluid or anything. And because these are drusins, you see that the area underlying these RPE elevations or these bumps are usually also show a presence of a shadow. A geographic atrophy, for instance, here we would see a thinning of the retinal pigment epithelium. So you see how over here you have the retinal pigment epithelium, which abruptly ends over here. And then you would have an area of increased signal over here. So you see this little cone of increased signal coming over here. This is because there's no RPE to attenuate the signal of the OCT. And hence you see it as a brighter signal over there. In terms of wet ARMD, it's very, very hard to miss. So if you would see a patient with wet ARMD and OCT, you would see these large elevations, which usually show the presence of subretinal fluid or blood. And these appear as black gaps or elevations. And you can see these under the pigment epithelium. This would be the choroidal neovascularization. You can see subretinal fluid or pockets of fluid here. You can see pockets of intraretinal fluid here. These are excellent in terms of a quick monitoring of patients. It's very good for follow-up of patients who are undergoing intravitreal treatment or management for wet ARMD. And it forms a very good visual representation to patients. You sort of convince them that they are improving, because we need to realize that a lot of these patients may not really show a major improvement in their visual acuity in the early stages of treatment. So This works sort of as a psychological reinforcement, because we are showing them their, before and after photographs, and they find it very easy to understand the importance of the treatment that they're receiving. Now, one of the newer techniques that have come into play is optical coherence tomography angiography, or OCT angiography. OCT angiography is a non-invasive test, if you will, because we're basically getting the benefits. It basically measures the presence of blood flow in blood vessels without the injection of a dye, and as a result is non-invasive, does not have any of the inherent side effects of the dye injection, can be done easily in patients with various comorbidities, and is also able to accurately image a choroidal easily, and sometimes even before we would notice changes on an angiography. So if you look at this this video over here, you see how when it's going down, the arrow here shows you the various layers that are being imaged in this OCT angiography, and as you go towards the outer layers, you will see that initially the picture appears absolutely normal, but then as you go deeper, as you go towards the outer layers, towards the choriocapillaris, you see this entire network forming over here of the choroidal neovascularization, and this is what is responsible for the damage in these patients. So for instance, over here, you see this is a superficial layer. It appears relatively normal. As you start going deeper, you see the outer retina shows a densely packed choroidal neovascular net that's composed of loops, peripheral anastomosis, and surrounded by a hypo-intense halo. So you see this area here is the hypo-intense halo. And on a spectral domain OCT, certain scans show no fluid, but if you look over here, you will see the presence of a subretinal fluid pocket forming, which would, be a red flag and have would sort of invite treatment over here. Now, ICG angiography, while is a gold standard for diagnosis of polypoidal choroidal vasculopathy, due to it has superior visualization of polyps and branching vascular network. It's unfortunately in our setup in Mumbai, it's very difficult to come across centers that can perform an ICG angiography. So until the advent of OCT angiography, this used to be one of our limitations, where patients who were not responding to treatment with anti-VEGFs, after multiple injections of anti-VEGFs, then we would suspect that these patients may probably have some sort of polypoidal choroidal vasculopathy, and we would get their ICG angiography done. Studies have shown that OCTA is comparable to ICGA for the detection of branching vascular network, and it even shows it with greater detail than an ICG angiography without the inherent problems associated with dye injections and the costs. The rate of polyp detection, however, is very variable. It ranges from 17 to 85%. So if you see in this video over here, you see the OCT showing a little bit of fluid here. And as we go deeper, we start seeing the presence of this polyp here in the center, surrounded by a hypo-intense hypovascular area. So here we have a comparison of a PCV lesion with a large polyp seen on OCT. There's a hypoflow round structure here. So you see the area here has hyper-intense margins with a less intense inside. It has a so that's called hypoflow. It's surrounded by a hypo-intense halo. And the details and extent of the branching vascular network. So you see this branching vascular network are seen better over here. So you can see the extent of the branching vascular network better on the OCT angiography than you can on the ICGA. The ICGA gives you a sort of like a blushed image here. And on an FA, usually it's very difficult to see the branching vascular network, because it's usually comes across as either a block fluorescence, but you may make out the presence of a polyp here. Now, coming to treatment and prevention. So primary treatment, a quick poll. How many of you would recommend vitamins and antioxidants to your patients with ARMD?
Almost
Okay,
half.
so I see, yeah, exactly. Quite a huge majority do recommend to ARMD patients. Quite a few of them do recommend to dry RMD, and a small group do not recommend. So, to be very honest, I come from I come from a group of physicians who recommends who recommends vitamins to patients. But the thing over here is that we need to make sure that the vitamins do not compensate for other forms of treatment. So a lot of patients, if they have economic problems, we have to sort of bring that into the play, because a lot of these vitamins are expensive. We're looking at quite a big chunk being taken up at monthly medical costs. So in terms of dry ARMD, usually there are currently no treatment requirements for dry ARMD, because as mentioned, the vision usually remains stable. There are presence of AREDS and AREDS2 vitamins. We will come to the details about these a little later. But the main difference here that we need to remember is that AREDS2 recommendations removed beta carotene and replaced it with lutein and zeaxanthin. This was done because it was found that in the AREDS2 supplement, the AREDS2 supplement to the AREDS1 study, it was recognized that the presence of beta carotene was associated with an increased risk of lung cancer in patients who were smokers. And as a result, beta carotene was removed because there was no major benefit found to that, and they added lutein and zeaxanthin instead to replace it. Now, patients with rare drusen, with mild ARMD or a strong family history can supplement with lower doses of vitamins and antioxidants, such as those found in over-the-counter multivitamin preparations. I usually advise home Amslers. We try and discuss smoking cessation. What's important to remember over here is that patients need to remember that they need to undergo routine examinations, and that vitamins cannot be the treatment. They're just a preventive form. So another poll here. What anti-VEGFs do you commonly offer to patients with wet ARMD? So if those in clinical practice and who come across patients, go ahead and answer this. Even if you don't recommend it, what are patients that you are seeing? What are they getting in terms of anti-VEGFs? It's more or less 50-50 between Avastin and ranibizumab, which is per expectations. Next higher number goes for all of the above. Okay, it's fine. The aflibercept and brolucizumab are relatively new. I wouldn't say no. Brolucizumab is relatively new, but aflibercept has been around for some time now. Okay, so coming to anti-VEGFs, I think there may be another poll here. Yes. Okay. So based on this, what do you think determines the choice of anti-VEGFs for your patients with wet ARMD? Is it cost? Is it safety of an intravitreal procedure every couple of days? Is it the availability? A lot of smaller places may not really have access to all forms of anti-VEGF, or is it all of the above? Okay, yeah. So it's all of the above. Yes. So the major problem here when it comes to treatment for something as chronic as age-related macular degeneration, which involves interventional procedures like even an intravitreal injection, cost is one of the major factors here. Now, compared to Western countries, I can give you an example. For instance, in India, where a lot of our patients either don't have insurance, or even if they do have insurance companies till very recently were not really covering intravitreal injections as one of the treatment plans. They are beginning to accept intravitreal injections, but however, they accept the more expensive injections. So if you're economically challenged, then it becomes a difficulty here to get an insurance company to reimburse you, as opposed to say in the West, where in Boston when I worked there, a lot of patients would come in like clockwork for either even diabetic macular edema or for even their age-related macular degeneration, and get injections every month, every 2 months, because insurance would cover costs there. So it was not a really very big setback in terms of problems with money. In terms of safety, yes, it's an intravitreal injection. There are issues associated with infection, with inflammation that we need to consider over here. And obviously, as I mentioned, availability, because cold chain maintenance here is very, very important. So certain far-flung areas may not have access to that, may not have access to all forms of injections. All right. So, in terms of wet ARMD, the keystone here has now become anti-VEGF intravitreal injections, which are first line of treatment, especially for subfoveal locations, because they are relatively safe. They prevent permanent retinal damage and the loss of central vision, which was associated with lasers, which were practiced prior to the development of anti-VEGFs. The commonly used anti-VEGFs are bevacizumab, which is off-label, marketed as Avastin or Zybev. We have ranibizumab, which was marketed initially as Lucentis, and now we have biosimilars such as Razumab. Aflibercept, which is marketed as Eylea, and Zaltrap, which is the off-label Zivaflibercept, which is used instead of aflibercept in a lot of economically sensitive areas. And we have a recently introduced brolucizumab, which was introduced during the last 6 months and marketed as Paganax. Now, while no significant differences have been found between the agents across multiple pivotal trials, aflibercept was found to cause swifter resolution because, in addition to VEGF suppression, it also has platelet-derived growth factor inhibition, and as a result, also has increased treatment intervals compared to others. So, in terms of economic sensitivity, this would be better because you're not really looking at monthly injections, even if you're following a continuous plan, and you're looking at bi-monthly injections after the initial loading period. So the next important thing here in terms of anti-VEGF treatment is the regimens. There are either fixed or variable regimens. The fixed regimens usually comprise of monthly or bi-monthly injections. Now, wet AMD is a heterogeneous disease. It has a very variable natural history. Patients may have a variable treatment response to anti-VEGF. They may have response to Avastin. They may not have response to Avastin. They may have response to ranibizumab or not respond to ranibizumab. And recent research has shown that VEGF suppression also is very variable. Many patients do very well without monthly treatment. So you may have patients who, some patients require monthly injections. There are some patients who don't require any injections after the initial loading dose of 3 injections. And some of them may need injections every 6 months. So in the fixed monthly treatment plan, it could result in over-treatment. Now, the problems with over-treatment include obviously the extra expense, both in direct and indirect costs. There's less convenience for patients, burdened with frequent visits, with an increased risk. With chronic injections, this could be endophthalmitis, glaucoma, and also exacerbation of the retinal atrophy, as well as systemic side effects, which are known to occur in some patients with renal issues or with myocardial infarction or stroke. This has been known to happen with bevacizumab and is a rider that needs to be mentioned to such patients. In terms of the variable regimen, we have the variable discontinuous, which was as needed or pro rata dosing. It's commonly known as a PRN dosing. This, I think, is something that I follow in my practice, and this is probably because my practice is in a more economically sensitive area. So the advantages of PRN dosing are there are less frequent injections, although they're not necessarily less frequent visits, because the patients do need to come in and we need to do their OCTs to make sure that there's no presence of new fluid despite stable vision. There's greater safety because we're not injecting as commonly. It's more cost effective because, again, we're not injecting on a fixed dose. We're injecting if the patient requires the injection based on clinical exam and based on OCT. And also the ability to identify the rare patient who may not need ongoing treatment. So a lot of these patients, if they're doing well, we may go in for a 6-monthly follow-up. However, the limitations are that the recurrence, there may be recurrence of neovascularization and leakage in the intervening follow-up period, and multiple recurrences. So if you have a patient who has a recurrence of fluid despite good vision, it may cause progression of disease with permanent visual decompensation due to permanent loss of photoreceptors. So this is one of the major limitations of PRN dosing. Now, in terms of variable continuous, we have the treat and extend strategy. Essentially, what this means is that we are injecting after the initial loading dose of monthly injections in these patients. What we are doing is we are going ahead and increasing the follow-up periods of these patients to a maximum of 8 weeks. And dosing is variable. It's individually catered. Usually there's no risk of over treatment and the burden is minimized. Safety is maximized because obviously we're not injecting these patients as frequently as in the fixed continuous regimen. It's cost effective. It minimizes the number of office visits, tests, and injections, and over various pivotal studies was found to be often as safe and as visually preserving as a fixed regimen. So here what we're doing is we do the initial 3 treatments, then we call the patient in at 6 weeks and then 8 weeks, and then we try and increase the treatment intervals. And when the patient comes in, we inject irrespective of the presence of fluid or presence of visual decline. So here, this is just one case report that I thought I'd throw in. This was a 64-year-old lady who was unable to see. She comes in with a large blood clot at the macula. So this obviously is a wet ARMD with presence of subretinal heme. This patient underwent monthly intravitreal ranibizumab injections, and at the end of 4 months, we had seen that the blood clot had resolved. Vision had improved from hand movements close to face to 636, and these are one of the few positive treatments that we get in these patients, and we have a happy patient here. Focal laser photocoagulation, the use of that has now been limited in the anti-VEGF era, mainly because if you're talking of lasering the retina, we're talking of permanent damage and permanent visual field defects, as it involves burning the membranes in the surrounding retina. Also, occasionally, when we cause a burn to the choroidal neovascular membrane, the area around the membrane can sometimes, through the scar, we can get a recurrence of the neovascularization. So though it was used initially, it's not now used for the central lesions. Some physicians do use this in extrafoveal lesions. However, anti-VEGFs work equally well here. So it's slowly being completely replaced by the anti-VEGFs. Now, photodynamic therapy, again, this is a specialized treatment for wet ARMD. It includes injecting a dye called verteporfin intravenously. This dye concentrates in new blood vessels and is activated by a laser beam. The activation of this dye in the new blood vessels causes localized thrombosis and resolution of the CNV. However, it does not improve vision loss as it may cause retinal damage. So what we're now using is we're using a half fluence laser, where low fluence PDT, where basically the retinal damage is minimized. This is also being replaced by anti-VEGFs in most cases. However, in certain cases, like as discussed, in presence of polypoidal CNV, etc., which are not responding to anti-VEGFs intravitreally, or in patients with very large pigment epithelial defects, which show the presence of a polyp, we do try dynamic therapy. There are certain drawbacks of photodynamic therapy, cost being a very, very important factor here. The second is also that verteporfin is a light-sensitive dye. So when we inject this dye IV, we need to make sure the patient is not exposed to sunlight and etc. All of the issues that go with any sort of intravitreal injection. So these are a couple of drawbacks that we have here. In terms of surgical treatment, it's usually not very commonly done. There are certain submacular surgeries that were recommended for removal of the subfoveal, either CNV membranes or blood clots in one-eyed patients. Macular translocation surgery was tried to surgically move away the fovea from the site of RPE scarring or the CNV. However, it's not very, very commonly done, so you will not really come across many patients or many physicians recommending this. Now, in terms of AREDS, we have the AREDS was basically an age-related eye disease study, and specifically to ARMD, it was designed to address the following question: does zinc and antioxidant supplementation slow the vision loss associated with increasing age, such as AMD and cataracts? So overall, their finding was that those patients with intermediate AMD, remember the classification that we just discussed, the presence of a few intermediate size drusen and one large drusen. So patients with intermediate AMD or those with advanced AMD in only one eye had a 25% lower risk of progressing to advanced AMD in one or both eyes when treated with zinc plus antioxidants. And patients categorized as having no or early AMD did not show a benefit with the high dose supplementation. So there was no mention over here of wet AMD. The current components, so initially we had the AREDS 1 formulation, which has now been replaced by the AREDS 2 formulation. But in terms of historical perspective, the AREDS 1 formulation came with 500 milligrams of vitamin C, 400 international units of vitamin E, 15 milligrams of beta carotene, or 25,000 units of vitamin A, 80 milligrams of zinc oxide, and 2 milligrams of copper. Now, smoking is one of the most important modifiable risk factors to prevent or reduce morbidity from AMD, and this was also one of the findings of the AREDS 1 study. However, if they choose to continue or if they have smoked in the last 10 to 15 years, they should not have beta carotene supplementation as it increases the risk of lung cancer. So as a result, in the AREDS 2 formulation, they replace the beta carotene with the presence of lutein and zeaxanthin. So essentially, everything else remains the same. They just removed the beta carotene from the AREDS 1 formulation and replaced it with lutein and zeaxanthin in the AREDS 2 formulation. In terms of supportive management, we have the presence of, we usually give these patients an increased near addition for reduced acuity. The other options obviously remain low vision aids such as telescopes, hand magnifiers, enlarged size prints. With technological improvement, we have enlarged screen size for TVs and computers, presence of closed circuit TVs or computerized magnification systems that may help these patients get back to some semblance of normalcy, some amount of decent near vision that usually does not affect their quality of life. This ARMD remains a condition in which follow-up remains very essential. Even if a patient has dry ARMD and is showing slow progression with relatively good stable vision, it may convert to the wet form anytime. So it is recommended to monitor vision and use a home Amslers and consult the primary care provider or retina specialist in case of reduced visual acuity or distortion. Wet ARMD may need monthly or bi-monthly injections and hence clinical visits. The visits continue irrespective of whether or not you're undergoing intravitreal procedures, because we need to monitor these patients with either an OCT or a clinical examination. Quiescent and scar cases need monitoring for recurrence. So it does not mean that once your disease has regressed or there's no fluid that we don't see you at all. And this needs to be emphasized to a lot of these patients. In monocular involvement, examination of the other eye is always recommended, because there can be cases where the vision in one eye is good to begin with, and then these patients usually have an occult disease or a new onset which presents later. So at every visit, it's always recommended to check both eyes, even if a patient is coming in for an intravitreal injection. So to quickly summarize, ARMD is a most common cause of irreversible central vision loss in people over the age of 50. There are two types, dry and wet. No treatment recommended for dry ARMD. Visual aids, lifestyle modifications, antioxidants may be given. Early detection and close monitoring is key for good visual preservation. And a lot of these patients may do well with rehabilitation and training with low vision aids. Thank you.
Okay, thank you so much, Dr. Hasnain. I think really comprehensive in terms of what is ARMD and what are the latest options in treatment. The AREDS 2, which is the highlight of this particular thing, what we need to understand, because that's the way forward now to know what's the management options which they have, modifiable management option for the AREDS 2. So thank you very much, Dr. Hasnain. And
thank you.
But just a couple of thoughts on this. You did mention that there was one question. I was just reading the chat earlier, that there is no particular option in terms of ARMD management.
Mm-hmm.
So the only option remains is monitoring and providing them with low vision aids. Am I right if that's needed?
Correct. So a lot of these patients may not really need low vision aids, because as mentioned, their vision remains pretty fair for a very, very long period of time, unless they have geographic atrophy or they are patients with wet ARMD, which is now converted to dry ARMD. Yes, I usually prefer to give these patients some sort of vitamins, some sort of antioxidants. It's very difficult to get, especially in India, it's very, very difficult to get exclusive AREDS 2 formulations. We usually have companies coming out with all sorts of formulations, with all sorts of mixtures in them. So I usually have a couple of my favorites which come very close to AREDS 2 formulations. I usually give these to patients. They contain lutein mesozeaxanthin, which is a precursor to xanthin, and it really helps these patients maintain some semblance of normalcy. It's very important to emphasize that yes, a monthly or quarterly examination is recommended, because like I said, in economically sensitive markets, it becomes very difficult to get the patient into clinic. What also needs to be remembered that a lot of these patients are old patients, so they don't have the family support, or they don't have the support to come into your clinic for a test. So that needs to be borne in mind as well. But yes, for dry ARMD, I would say a routine follow-up examination is key.
Is the key. Yeah, that's right. Yeah. So there's one question here. Recommending injection is variable and continuous. Is it, or any thoughts about this? Because
So as soon as a patient, a patient who comes to you with complaints of declining vision, and you take a look at the patient and you see the presence of subretinal fluid, or you see the presence of subretinal heme, and an OCT shows any amount of fluid underlying the fovea or parafoveal area, you start the patient on anti-VEGF. That's the primary form of treatment now. And the way I recommend it is, I usually recommend that the patient undergo monthly injections for the first 3 months. And after that, we usually take a break based on what injection I'm doing. I call the patient at 6 to 8 weeks after the third injection. We do an OCT. And if the OCT shows any form of fluid, we inject. If the OCT shows no fluid, we stretch the examination period to a maximum of 8 weeks, and then we keep following up the patient to make sure that they're coming in. And if and when we see fluid, if and when we notice a visual decline, we go ahead and inject the patient. So that is the way we usually try and do it, because again, India is a very price sensitive market, and it's not possible to have patients undergoing a fixed monthly or bi-monthly regime.
that's right. And when would you normally refer them for low vision aids? Is it
So a lot of these patients, for instance, if they have geographic atrophy with a central scotoma, I would recommend them for low vision aids. If a patient is relatively stable on intravitreal injections, if it's a patient of wet ARMD, which has now progressed to quiescent dry ARMD, then I would recommend that they undergo low vision aids, because it would help them utilize whatever little bit of central vision they have, whatever little bit of paracentral vision they have, with the use of prisms, etc., to help see near.
that's right. Okay. And talking about these injections, normally do they come in unit dose, or there is a valve which you can use it for many patients? I guess that.
So, in terms of the off-label injections, the ones such as bevacizumab, zivaflibercept, they come in reusable vials because they basically off-label use. The ones such as ranibizumab, which are manufactured either by Novartis or Intas, and the presence of crolizumab or Eylea, they usually come in unit doses, which are meant for one patient use, and hence one of the factors behind the higher costs for these injections.
Yeah, that's right. Okay. And how frequently do you want to perform an OCT examination? Because that's where our role as optometrists would probably come in, because we would definitely help, in co-managing the condition by doing the diagnostic tests. So how often do you recommend? Is it on every visit when the patient comes back, like you said, 6 weeks and 8 weeks probably? Is that the time, or you'd want
So
to monthly?
again, over here, it sort of depends on what sort of practice you're in. In my practice, my protocol here is that I usually try and do an OCT prior to the commencement of injections. But again, over here, I sort of look at the patient and in terms of their economic health, because in OCT also is an expensive test, and all our centers don't have an OCT. So if we are supposed to send the patient to get an OCT done, there will be another big chunk out of their treatment plan. So what I usually do is, if I see an obvious presence of subretinal fluid or heme, I try and not get OCT done because I know that there is fluid there and I start the treatment off immediately. However, in a standard case, I would do an OCT prior to the initiation of treatment. Then I would do 3 injections at monthly intervals, and then I would repeat the OCT at month 4, and then thereafter, say at every 6 to 8 weeks.
All right. Okay. Because that's again an important aspect in terms of optometrist's role. That's
True.
why I asked you how frequently would you want to do? Because again, when we are doing the counseling part to the patient, we'll have to tell them that these are the certain tests we would like you to repeat, and this would be the frequency of the test, and probably the cost factor would also
So
be involved.
again, off the record over here, but a lot of centers, if they have an OCT, a lot of centers that I know do an OCT at every visit, because that not only adds to our clinical armamentarium in terms of imaging studies that we may have, but we can also use it for research purposes, we can use it for presentation purposes, and we can use it for patient reinforcement. But if you're doing the OCT at every visit, we usually the patients are not charged for it. If the OCT is being done at certain fixed points, then the patient is charged for those tests.
Okay, so you can work that out, I think,
True,
with
true.
plan and with the
A lot of
package.
patients have, a lot of centers have plans. So I mean, they usually include couple of OCT tests, etc. And in the treatment package, if you will, when they're
Yeah.
being charged for injections.
Thank you very much, Dr. Hasnain, for giving us your time and taking up this session. This is a very interesting and AREDS 2, I think, is the latest one, which I think probably not many of us would have known that there is a change in the management, which probably would incorporate into advising our patients now.
Hmm. True.
We also have a case presentation series which have been planned, and thank you for a lot of people who have sent in the abstracts, and we are keeping the abstracts open. The submission for the abstracts is still on, and we would request, if you have any interesting cases which you would like to present onto our platform, you're welcome to submit your abstract, and the scientific committee is going to look at it and make sure that you have been planned for the presentation onto our platform. Thank you everyone for attending. Thank you, Dr. Hasnain, for taking up the time once again from the entire team online Optom Learning Series, as well as all the attendees. Thank you very much.
Thank you for having me.
Most welcome. We do have session planned next weekend. Stay safe, take care, and very I think it's an early wish, but probably we would meet next week. But I would like to wish everyone to have a safe Diwali season. It's a festival season now in Indian, as well as most of the parts of the world. There is a festival season now, so I would like to wish everyone happy Diwali and take care. Be safe. I will see you all again next week. Bye bye. Thank you, Dr. Asnan.
Thank
Bye.
you, Fakhruddin. Bye. Bye.